introduce you now to Dr. Annick Desjardins. And thank you, Doctor, for joining us today. It's a little bit later on your end if you're anywhere near Duke. Dr. Desjardins, she's a professor of neurology and professor of neurosurgery, and she is the director of clinical research for the Preston Robert Tisch Brain Tumor Center at Duke. Her primary focus is patient care and clinical research as a neuro-oncologist. Her clinical research focus is providing innovative and aggressive therapies to adults with primary brain tumors. She always keeps the patient's quality of life foremost in her practice. She completed her residency in adult neurology at the University of Sherbrooke in Quebec. She finished a 2-year fellowship in neuro-oncology at the Preston Robert Tisch Brain Tumor Center at Duke. And upon completion of that fellowship in 2005, she joined the center as faculty. She is a fellow of the Royal College of Physicians of Canada. Dr. Desjardins, thank you so much for joining us today. I'm super excited about your presentation.
I'm excited to be back presenting at the End Brain Cancer team. They're fantastic. I remember being there in person in 2016. So to meet all of you by the webinar is really exciting for me. So I wanted really to talk with you, and it goes well following Dr. Golden, because Dr. Golden mentioned something very important with the Optum Geo about the fact that we prevent complication from what we call systemic complications, so complication from taking a chemotherapy by the mouth or intravenously. So this is also type of things that we try to do, that really I'm focusing my research on how to really go where the tumor is and try to prevent other side effects. So today what I want to talk with you about is really our novel immunotherapy delivery technique. So how do we get our medication or new treatment into glioblastoma patient and really have the maximum efficacy? Here are my disclosure. And really talking and why it's important, really thinking about, if you look at this FDA approval in primary brain tumor of the different agent, we really don't have much approved for glioblastoma. The last couple of years, we have seen approval of new drug for medication or tumor with specific mutation, the V600E that are mostly seen in children with brain tumor, the SEGA, and then the recent approval of IDH inhibitor, so vorasidenib in August of 2024. So all big discovery, but really in glioblastoma, if we're thinking about glioblastoma, lomustine, carmustine was approved in the 70s, then we had Gliadel, and then the temozolomide 2005, bevacizumab or Avastin 2009, and then the Optune Geo, I still had it under Novo TTF, really approved just beginning of 2010. But really since then, no significant approval in our brain tumor patient. Why is it hard? Most of you, I don't need to tell you why it's hard to treat brain tumor. Really, as we know, this is a tumor that is really infiltrative into the brain. It is really hard for the neurosurgeon to get a complete resection. And there is this whole issue of the blood-brain barrier. And here is a really example, what is the issue when we talk about the blood-brain barrier issue in our drugs not being able to reach the tumor, all the tumor is really, this is a great example. So you have here a case, where the patient had surgery. This is what we see of the enhancement, the contrast enhancement. And then what you can see, however, so you think the surgeons are able to remove this. But if we look at what we call the flare images, where we would say we see the edema, but really the edema for us is an indication, where is that infiltrative disease? And all of that, the surgeons just cannot go and remove that. So there is a lot of the tumor cells that we just cannot reach right now with our treatments or with the surgery. Because the other issue we're facing, this is highly heterogeneous tumor, meaning that even inside the this area of tumor or a little farther, where is the infiltrative disease, the genetic makeup, the mutation of the tumor are very different, and they're very different from patient to patient, but also different inside the tumor. And the issue of really that the fact with the blood-brain barrier, with this diffuse infiltration, we really call tumor cold tumor, meaning that there is not a lot, the immune system really cannot see our brain tumor. They cannot see GBM. It's just hiding behind the blood-brain barrier, which is very different than other tumor like melanoma, lung cancer, that have like great success with the novel immunotherapy, like the checkpoint inhibitors. And then another thing that for me is always very important is the fact that our brain is who we are, right? That's our computer. That's really what makes us us. And then the impact of the tumor on our day-to-day functioning, on the loss of wages because we cannot work anymore, on the need for our caregiver to be there, right? As also a very important impact that makes it hard to treat brain tumor. You have heard today about like different treatment. We just heard about the Optune Geo, and I know earlier you had other therapy, but really one thing that we're focusing on is really immunotherapy. So instead of using high dose radiation, high dose chemotherapy, how can we activate the immune system? How could we build in how I describe it to the patient? I always say it's like if we have our own little built-in Pac-Man, how to activate them to look for the tumor. And there's different forms of immunotherapy that are being tested, the checkpoint inhibitor, different vaccine, viral therapy, CAR T therapy, tumor-infiltrating lymphocyte, antibody toxin conjugates, a lot of different immunotherapy. And I'll talk about, right, the ones we're focusing on or that I'm focusing on at Duke. My colleagues are working on others. But really, and what are some of the limitations and how we're working around it. One of the things that is clear is, I mentioned, so checkpoint inhibitor is a form of immunotherapy that is used, that as I mentioned, has had great success in other cancer. This is an example of lung cancer, where when they did the study in lung cancer patient, right, really showed that compared to standard chemotherapy, when you added the checkpoint inhibitor, you clearly improved the survival of patients. The problem with those checkpoint inhibitors, they're given intravenously. They're called antibody, which means that they're big. They cannot really reach the blood-brain barrier. And we have tested it, and this is one of the study, right, where it was tested against bevacizumab. And we have tested it also against radiation and temozolomide, the standard of care. But really in brain tumor patient, because of the issue of reaching the blood-brain barrier, because of the issue of having very little immune cells inside the brain, we have really not shown any efficacy right now with the checkpoint inhibitors trial. We're looking now at combining it with other agents like, right, the vaccine, the CAR T therapy, right, the oncolytic viruses. But so far, right, the data we have is that really has not created much benefit to our patient. So what we have been working, really what I've been working the most on since, in fact, 2012, is really of how to get drug directly to the tumor, right? How to get a new agent. So this is the new delivery technique, right, I was mentioning. So instead of giving the drug intravenously, instead of trying or by the mouth as a pill form, how to just like infuse it directly into the brain. And you can do that different ways. There is some that would use, do the surgery and inject the medication in the wall of the surgical cavity. We decided to go a little differently, and instead of like more to mimic how fluid normally works or travels into the brain, what we decided to do is really use a technique called convection enhanced delivery. And what convection enhanced delivery means is that when you have a tumor regrow, Herner or, we're working now toward going for a new tumor, the surgeon can put a tube, a little catheter inside the tumor, which is very similar to what they will do if they were to do a brain biopsy. So they inject a tube, and then we slowly infuse. So we infuse at a rate of, we call 0.5 ml per hour. So it means that a teaspoon, right, 5 ml will take about 10 hours. So we slowly infuse the drug to really mimic how fluid works and travels into the brain. And the advantage of that is really our goal is to try to coat as much as possible of the tumor cells with our drug, with our agent. and to not disturb as much as possible the normal anatomy of the brain, so not trigger seizure, not trigger headache, but to slowly infuse a drug. And then when it's removed, we remove the catheter. So this is a convection enhanced delivery. So we insert a small catheter in the area of the brain. There is a pump that slowly push very carefully the medication. And the cool thing about that is, we're doing the trials here at Duke right now, but we're not the only ones that use this technique. And because it's really similar than just doing a regular brain biopsy, once we get a drug that we show will be effective, this can be repeated pretty much anywhere where you have a brain neurosurgeon that knows how to do brain biopsy. And this is really an example of one of our patients where what we did here is really, so this is the hole from the surgery. You can see in the bottom, this is an MRI without contrast. You can see at the bottom, that's where the tumor is. The catheter is in place. And what we did with this is that we mix instead, in fact, of giving the contrast intravenously, like we normally do when you get a brain MRI. What we did is we mixed the gadolinium with the study agent that we infused to really show that by infusing back the catheter slowly, we can really coat the tumor with our study drug. We have tested, so the convection enhanced delivery, so I was telling you, I've been working on that now with our neurosurgeons here at Duke now since 2012. We have treated over 360 patients. We have treated with this technique. You might have heard about the genetically modified polio virus. The new name is called Lerapolturev, so use polio. We have other agents. This is using what we call the Pseudomonas exotoxin. We have used CAR therapy, and we have collaborated. We have worked with different companies that have also had us test different agents that we inject directly into the tumor. So I'll give you a little bit of data on, or show you where we started, where we are today, and then also where we're moving forward to. So this is the data on the polio virus. And in 2016, when Dylan and me come meet the team in person, really, we had talked about that. And in fact, Stephanie, our first patient, was with me when we went, but really showing that when we did the genetically modified polio virus trial, in that trial, what we were doing is the patient had one single tumor growth. We were putting the catheter inside the tumor. We were slowly infusing over 6 hours the genetically modified poliovirus, pull the catheter, and that was it. Patients were getting one single treatment, and then the tumor will get inflamed, angry. This is an immunotherapy, so you're faking an infection. It gets angry, gets inflamed, like if you're having, something that gets infected. And then with time, the immune cells just destroy the tumor and it just contracts. In those patients, the study here, so that was published in 2018, really what we showed that part of the study in our glioblastoma patient, if we look at the red line is the patient that were treated with other trials versus the blue line, the GBM trial. So this was a single brain injection. And really what we showed is the patient, the drug, the single brain injection was not working great for the patient that the tumor was growing really fast or had very weak immune system, but we still had this group of patients, 20% of patients that became long-term survivor after tumor regrowth, where really normally you're told if your tumor comes back, there is very little chance that we'll be able to talk about long-term survival. But we were able, by a single brain injection, to have 20% of patients that became long-term survivor. Of course, that's not acceptable, Every single day I meet with patients and family like yours or like the ones you're taking care of, and we need to help more than 20% of patients. So really what we have been looking at for years is how can we retreat patients? How can I be able to infuse in the brain multiple times the virus and do it safely? And the team in Japan, so Dr. Toto has published that, was able to do it, where what he did is every couple of weeks, every couple of months, for 4 to 6 doses, he went in and he injected the virus, which he could do safe, which he showed it was safe. He was able to retreat the patient. The problem is it's hard in the United States to get that paid for. You would need to have your insurance company agree that we put we bring you back to the operating room every 2 weeks or monthly to get a brain injection. So you can imagine that would be extremely expensive. And then the risk, the trauma. So we look We said, okay, that's feasible, but how can we do it better? The other reason why we wanted to do that is what we had realized is in our poliovirus patient, I was telling you 20% of patients became long-term survivor. And in those patients, when their immune system got weaker and the tumor came back, so you can see this patient, the tumor was in remission for 70 months, this one 35 months, this one 60 months. When the tumor came back, we did a second brain injection of the polio and it worked again. It gave again the patient, right, 12 to 20 months, which is much better than the data you will expect normally. So all of that, I've been talking a lot just to say, so we have figured out with polio that in fact, if I was able to put the catheter in and do double brain injection only 4 days apart, I don't need to wait the 2 weeks or the 1 month that Dr. Dodo, the team in Japan did. Really, if I put the same catheter, and this is the animal data, we put a catheter in, we inject inside the tumor, we leave the catheter in place, and we inject a second time 4 days later. And this is really just to show. So this is the animals without polio. This is the animal with 1 brain injection. This is like how much we help with double brain injection 4 days apart. So really, we have figured out a way that we can treat the patient twice, trigger a better immune response, and really without having to bring back the patient to the operating room, without triggering a new bill to the insurance company, without triggering an additional trauma to the brain. And that's what we're doing right now. So we have a trial. This trial is now started, where really what is happening is our patient at the time of tumor regrowth, the catheter is inserted, and we leave the catheter in place for 4 days. We do first injection, normally it's like on a Monday, 6 hours of the polio. We leave the catheter. We just put a bandage on it. And then on the Friday, we do the second brain injection of 6 hours, and then we pull the catheter out. And really, we should see the same thing of long-term survival in the patient, that, improvement compared to single brain injection. That, again, single brain injection, 20% of the patient had benefit. By adding the second brain, what we expect is we'll have much better improvement. The other thing also that we figured out, and that's, I will talk with it on the next slide, is really the fact that I was telling you, right, checkpoint inhibitor don't work great in brain tumor patients. They just don't cross the blood-brain barrier. But really what we have figured out is that in the neck, we have lymph nodes, and the immune cells that goes attack the tumor are living in the lymph nodes of the neck right there. And so what we started doing is that we inject our medication in the brain, so the double brain injection with the polio. And then after that, instead of giving an intravenous checkpoint inhibitor that cannot cross the blood-brain barrier, in fact, what we do is we go and we inject those checkpoint inhibitors. So we have, it's called an anti-CD40, and I'll show you some of the result, or the poliovirus in the neck area every 3 to 4 weeks. And really the goal of that is I'm triggering the immune system to start attacking the tumor in the brain. But then after that, I'm keeping the immune cells alive, active, by injecting around the lymph node and telling the immune cells, you need to stay awake. Don't die. Don't give up. Keep going into the brain and fighting the tumor. And so this is a trial. In fact, we have already been going, and I showed the data, right? This is another one of our agents that we inject in the brain called D2C7. And we do, so the patient get the brain injection similar to the poliovirus. And then after that, we start once a month. We just changed that to once a month, the injection around the lymph node, and really showing that those patients that were glioblastoma patients, that when the tumor comes back, we expect that the survival is normally about 6 to 8 months. We had patients, right, that we were still treating patients, so patients that are still early, but patient at 20.6 months still doing really well. Patient able to get up to 23. Now it's more than that. Like I have patients that are more than 27. Injection in the neck of the checkpoint inhibitor, their immune system stays strong, they remain in remission, and there is no bad reaction. I know I'm running out of time, but there was another cool thing that I wanted to talk about. I'm going
You're okay.
Okay, it's my last slide. But another thing, so so we're excited. We can treat in the brain twice with one brain procedure. We can keep the immune system active by using the lymph node instead of intravenous. The other thing also that we're super excited about is we are collaborating with this group called XVADE. So I call it the Tumor Monorail team. They came up with this little catheter, and some of you, if you have heard about an Amaya catheter, so it's a small catheter similar to the Amaya that we can put, this is an animal, we can put the catheter in the tumor and it pulls, you see, in the animal we can do it because we can get, right, close MRI, but we can pull the tumor inside that reservoir and collect it. So what is happening? So the catheter is lined with this fiber, it's a nanofiber that will pull the glioblastoma cells inside. And we have now treated our first patient where we have put the catheter in. What is the usefulness of that? Is that now it's allowing us to sample the tumor without having to go back. We can just put a needle in that small reservoir right there and collect tumor cells directly. So the tumor cells, the tumor fluid is growing into the catheter, and we can collect the tumor cells in this reservoir and know, is our patient responding to the immunotherapy? Is the immunotherapy given up? And not after repeated brain biopsy. So we're really excited about that because that's really a discovery. The patient is tolerating really well. And we are able, we just a little bump, really nothing we can see under the scalp, but it's allowing us to sample. So I cannot give you what we're collecting right now and what is representing, but so far we are able to see tons of protein. We're able to follow over time how it's changing, how it's responding to the immunotherapy, and when the immunotherapy gives up and why it gives up. So in conclusion, I mean, we all know it. That's why we're here, right? We need to help our patient. I'm super excited on how we're continuing to work and developing new therapy, how to go directly to the tumor, how we can try to minimize having also to bring you back to the operating room. But at the end, right, is really just everything the patient do. And thank you, to all of our patients. I must say, all of my patients, the main thing they say is, I'm afraid I'm not giving you enough data. I'm not helping enough the next patient. So again, thank you to all our patients, their caregiver, and from the whole team. And this is the Duke team. So thank you. I hope this was useful and interesting. Thank you.
Thank you so much, Dr. Desjardins. There are a couple of questions. Are you available to answer some of those?
I am, absolutely.
Oh, can you tell us about how to increase efficacy of dendritic cell vaccines, especially unmethylated GBM?
Oh, this is a great question. So we're looking at that. Yeah, the dendritic cell vaccine. So we're looking at different options, right, with the dendritic cell vaccine of how to increase the efficacy. The same way we're looking with the virus. I was telling you, about virus today, but removing the tumor, adding a chemotherapy first to maybe, right, make the tumor, I'll describe it to the patient, make the tumor weaker, right, and less aggressive, or eliminate, what we call the bad immune cells, the Tregs. There is different way of adding the checkpoint inhibitor. That's where I was showing you the data where the checkpoint inhibitor on its own doesn't work better than just radiation chemo or, Avastin. However, when you combine checkpoint inhibitor with dendritic cell vaccine, will it help? So there is lots of different ways. We don't have the answer yet. The same way, right? I always say this, the way I describe it to the patient, right? It's really a stepping stone, and I showed you a few of the stepping stone that we have done in the last 12 years with some of our agents, but it's the same thing that is happening that we're doing with the dendritic cell vaccine, all of our immunotherapy.
It's very exciting. I'm really excited about the tumor monorail device.
I'm really excited. And I can tell you the first patient brave enough that did it is really excited too. It is really cool.
Question. I think it's related to the polio trial, but I'm not 100% certain. What was the recurrence percentage within the 20% of long-term survivors?
Yeah, so the answer, right? So the 20% of long-term survivors, so you saw some of them recur right at like 70 months. So not all of them have recurred. A number of patients are still in remission at this point. We're still following them. A few of them, the tumor recur at some point, but as you saw, as we retreated, they benefited again. I think the question is more, right? We know not only glioblastoma survival at a recurrence, we're talking not in years, but we're talking in months, and really figuring out how we keep getting the immune system active. And that's what we're hoping we'll do with the injection at the lymph node of the neck. So I don't have the number because we still have many of them that are still in remission, to be honest with you. But I would say probably like half of them, we have to talk about other treatment at some point, but it's still better than, 20% at 3-4 years still alive was, in remission was still much better than what we had seen in the past. And some of those patients made it 7-9 years at this point.
Which is fantastic.
CMV CAR T is promising. Yes, CMV, all of the CAR T, right? The problem with the CAR T therapy. I'm sorry, Dylan, I jumped on it.
No, you're good. You're good. You're great.
All the CAR T therapy, right? We're all excited about it. I'm sure you saw the great result, right? The team at City of O, Pittsburgh, right? Mass General has great data on that. We are reworking ours. The issue where all of us have is the CAR T is really, it works really, really good at the beginning, but then rapidly our body develop antibodies against it. So we fight the CAR T. So how can we make it persist longer? So that's the next step, how to keep the CAR T therapy longer in the brain, which is a little different than the approach with the polio that we were talking about, because the polio is we're not giving you an immunotherapy that we grew in the lab. We're more like activating your own immune cells.
Related to the polio virus, yes, it's still available at Duke. Where else in the United States is it available?
Yeah, great question. Unfortunately, right now, just because of funding, we have been obligated to close the other sites. We didn't have, unfortunately, the money to keep open the other sites. So right now it's only at Duke. We are, of course, looking at how to get more funding. So we want to bring it back, right? That we did the study with the team at UCSF, Mass General, Dana-Farber, Cleveland, Hospital Cleveland, Jacksonville, Florida. So we had done the phase 2 multi-site trial. We were able to prove that they had the same result as us, that 20% of the patient became long-term survivor with the double brain, the one brain injection. So yeah, we're looking at the funding to bring the double brain injection and the injection in the neck to the other side. Money.
Fantastic. Is that like NIH funding?
Anything. We're open to anything.
Okay. All funding options.
Any funding. Right now, the trial is open at Duke based on a generous donor philanthropy.
Oh, okay. Fantastic. This is the last question just because of the timing. I want to ask you this question because this is from a patient who resides in near Duke. You decide how you want to answer it. And then I feel like I'm going to put this patient in touch with you.
Okay.
I'm having surgery on May 20th for a biopsy. I'm unsure if it's cancer right now. What should I prepare for? I understand now that preservation of tissue is important if it's malignant. I'm going to say it's important even if it's not malignant. What should I request my surgeon does? Should I have the surgery or wait, or maybe be seen by a different specialist, neurosurgeon, that would be recommended to them? That's a question.
It is a loaded question.
It's a big question.
It is a big question. So I think that really having the conversation, right, with our surgeon is really important. You feeling comfortable with your neurosurgeon, it is for sure that you want to understand the risk and you want to make sure that the tumor, right, that is removed, that it's sent for all the testing possible also to get all the genetic, right, the sequencing of the tumor. So yeah, Dylan, I think that's the only thing I'll answer. Please, more than happy to help.
I'll put you guys in touch.
Yes,
I actually do have one more question. I think I know the answer, but I'm not 100% certain. Convection Enhanced Delivery, CED. It's the slow delivery. Is that done in the hospital setting or can that be done, outpatient?
Yeah, no, great question. We have a trial where we injected one of the multiple agent I showed there that we were able, in fact, because we were able to inject it in the outpatient setting. So it is now, we are working on that. We have another protocol right now that we're bringing in, that we're just starting, that will also allow injection at home. So the answer is yes, it's in the work.
Awesome. That's
Yep.
wonderful. Keep us posted. That is incredible.
It's really exciting.
Thank you,
Thank
Dr. Desjardins. It's so good to see you. I want to
Yes.
say Dr. Desjardins is also on our medical advisory board. We thank her so much for her passion for her patients and her research and all the help she's provided us along the way as well. So thank you. Keep
Thank
up
you,
the
Anna.
great work, my friend.
Thank you. You too. Thank you. Thank you, everybody. And thank you, the whole team at the Hand Brain Cancer. I appreciate it. Thank you.
Thank you.